Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I am joined by Ryan Myers. Thank you so much for joining me today, Ryan.
Yeah, thanks for having me.
So Ryan is the CEO and co-founder of an exciting new company called CranioSense. So how do you make sense of the cranium, Ryan?
It's a great question. There's a lot we still don't know about the brain. It's kind of the last frontier in medicine on a lot of levels. And, we're trying to do our part in exploring that mystery still by unlocking something that's only available via invasive procedures today.
Usually, yeah.
Yeah.
So as an ICU nurse, I worked with a lot of neuro patients who had to deal with a lot of different drains and, like you said, invasive procedures that were necessary. And there was a lot of risk involved because that was the only way to save people's lives a lot of the time. But CranioSense is actually developing and proving the viability of a non-invasive way to measure intracranial pressure. And now, Ryan, is this something you made up? Like, are you a brain doctor? Where did this come from?
Yeah, no, it's a great question. I mean, I think the genesis of it in general was it's always been a need in the space. So it's neurosurgery often refers to it as their holy grail because the only way to actually assess it or monitor it today is on their side is through a hole in your head or a hole in your spine. And so when we went on tackling this, I was working at a company doing early research and development, primarily under grants and building out a neuro portfolio. We looked at it a little bit differently. Instead of just looking at the brain by itself, we borrowed some old tricks from mechanical engineering and decided to make a pressure reference point on the body, which was, we thought, very straightforward, but had never been tried before. And I think that's a nice mesh between, where we came from, which is a very biomedical, mechanical, and electrical background, and then adopting new near-infrared approaches to really tackle something that was, until hopefully now, an impossibility.
So how far along are you with this? Like, how proven is this at this point?
Yeah, great question. So we actually use a biomarker that has been used in other spaces. So, but in a very different way. So pulse transit time is a technique that looks at essentially when your heart beats, how long it takes to get to another part of your body. And what it's been used for traditionally is in blood pressure, right? So cuffless blood pressure was always this really cool, fantastic need. And finally in the 2020s, we're able to get an FDA-approved device to market. Actually, there's two now, one that kind of sits on your wrist and one that sits on your chest using that biomarker. The interesting part was that you couldn't, you needed a baseline for each of these patients, right? Because there's so much going on in the body. And what we did was we said, well, we can use that same approach that has been able to measure pressure in a very unique way, but we can actually compare it at two different sites, one, the brain, and then one, test site. And by doing that, we create that pressure reference. And so we've now done a healthy human subject study where we said, hey, is this even going to be feasible? And we had great correlation between what was an assumed pressure and then our readings. And then we took that to the ICU. And we were able to look at those invasive sensors compared to our sensors and see how correlated that was as well, and came out with a really high potential diagnostic accuracy. So now we're taking that to another study, which we'll need to get through the market, and we're doing that at Mass General via lumbar puncture, which is the hole in your spine. So I always say we're halfway through, but but we're building evidence because that's honestly what patients and doctors are going to be relying on.
Yeah, definitely. And it's so important to be able to make as much of a diagnosis you can with as little invasiveness as possible, because every time you open someone up in a way, you're opening them up to infection or another complication. Like if you have a lumbar puncture, there's a risk for that CSF to continue to leak out. And so cerebrospinal fluid is really important to keep your brain floating in your skull. If you don't have enough, then it sinks down and you begin to what's called herniate. And I would just want to provide a little bit of context here, not to sound too scary, but at the same time, it is pretty scary because in the event that this starts to happen, now herniation can happen from too much cerebrospinal fluid accumulating, like if it's not draining out, it can then put pressure on the brain and cause the herniation to start. But if too much comes out, you can't put it back in. You have to wait for it to make more. And so it's a very delicate balance and you don't want to open up any of those barriers if at all possible. So a lot of times you'll do scans like an MRI or a CT to look at what's going on in there without poking any holes. But having something you could wear externally to at least have kind of a guesstimate or a more educated guess of a potential cause for different things. Now, what I was taught in nursing school and what most nurses are taught is to watch for Cushing's triad to indicate high intracranial pressure. And that's a combination of high blood pressure, drop or low heart rate, and then irregular breathing. And that comes together into Cushing's triad. And if you've got all three of those, you're looking at a medical emergency that's probably going to require a neurosurgeon to poke a hole in there to relieve that pressure, essentially. Yes. It would be great if we could do something before we get to that point to prevent it to be so drastic. So that's something that I definitely was not really aware of before nursing school, before working in the ICU. So Ryan, how in the world did you get interested in this? Did you come from a purely business background, or tell us a little bit more about that?
Yeah, no, it's a great question. I came up through the engineering ranks, so I did a lot of work in the medical device space, and then both while and then after I got my bachelor's degree, and then went back for my PhD in a neurophysiology lab, and then after that wanted to make sure that all the research that I was doing or any of the research that I was doing in general was going to get to patients, right?
I've heard like the translation for research is usually like it takes 13 years for research to make its way into practice. So what I'm hearing from you is that you wanted to shorten that time frame and actually see your work come to life in your lifetime. Is that right?
Yeah, absolutely. And I hooked up with a early research and development lab where we were getting grants from the Department of Defense, and traumatic brain injury probably is not a big surprise to your listeners, but is a big thing in the Department of Defense and in warfighters. And so they're having just as much of a hard time identifying who's had a traumatic brain injury and what's going on in the field as we have in general medicine in the U.S. So a lot of the early research came from that side. Worked with an amazing team, and we were able to advance it to a specific level. And then eventually, most engineers, if they want to see things get to market, and they don't get to be engineers anymore. So I had to very much switch to a business role. I got my MBA in entrepreneurship and M&A from UIUC, and since have been making sure that somehow the business and the science come together at the same time. So hasn't taken us 13 years yet, but I think that's the nice part about being able to move faster and some of the grants that we were able to secure. So
yeah, that's exciting. And you were talking about people who work in the Department of Defense, in the military, but lots of people participate in sports and are getting traumatic brain injuries and concussions that way. Also, auto accidents, just falls can result in a lot of traumatic brain injuries. Do you have stats on what the incidence or concern for intracranial pressure being high is?
Well,
as part of your market research?
Yeah, it's interesting because, market research has been kind of difficult. There's no tool out there to there's no blood pressure cuff for our brains, right? So we don't know precisely, I think, what the incidence rates are for certain conditions, right? But we know there are suspected 69 million traumatic brain injuries globally each year. Now,
Okay.
most of those, the vast majority of those, don't reach the triad.
Hmm.
But what's interesting is that is kind of easy to detect now. And to your point earlier, like not letting it get to that point or not letting somebody
Yeah.
go home that is like sub that threshold is really difficult for people or for doctors and hospital systems, because it looks like a headache. It looks like a bump on the head. CT and MRI aren't really great at picking up concussions and traumatic brain injuries, and especially elevated pressure. And so we're relying on, one doctor kind of coined it, uh, he relies a lot on Gestalt, right? Which is unfortunate and not,
Basically his gut,
yeah,
right?
is gut,
Yeah.
right? It's
Yeah.
not really their fault. Like it's nobody's fault,
No.
because there's no tool out there to do it today. So, you know, from concussion to traumatic brain injury and what the over 25 different medical conditions connected to elevated brain pressure, we're making a diagnostic to make it easier to say, is this a headache or is this something more?
Yeah. And, we could look at chronic migraine sufferers, right? And see, is there a fluctuation in their intracranial pressure at the times when they're having these headaches?
Sure.
Because there's a lot of things that can contribute to the condition of migraine. So having additional ways you can study it
Mhm.
could be really helpful, because you don't want to poke a hole in somebody's head or spine just to do this research. So if there's a way, this could just open up a whole new world of research that could really impact women, I'm thinking, as
Yeah.
women in their 30s and 40s are generally experiencing a lot of headaches. And so having an additional way to diagnose, is this a contributing factor to the
Yeah.
headaches, could make a difference for some people.
No, it's a great point. I mean, chronic migraine is when you have a migraine every other day. I think honestly, most people have probably had a migraine at least once in their life, and now imagine that every other day. And for a lot of patients, drugs tend to work, but for somewhere between 10 to 30% of those patients, which is almost it's like 1.3 million people in the US, we actually now think that elevated brain pressure is actually contributing to that chronic migraine.
And
And the
who is
hardest
we?
part, who is we? The published research, right? I think that's actually the hardest part, because these studies were done retrospectively, looking at lumbar punctures, looking at right, and so all we have is anecdotal. That number could be much higher, especially with people that are not responding to drugs,
Mm-hmm.
traditional migraine medications. And so, yes, just being able to just research that to understand the incidence rates, how we can treat these patients, because there's treatment, right? There's medications for elevated brain pressure, differently, so that they can actually have a reasonable quality of life, so that they can live with maybe one or two migraines, or hopefully no migraines a month.
Right.
But yeah, 90% of
One
women.
of
So
one of my favorite neurologists would probably chastise me if I was remiss to just say, um, migraine is not something you just have once. Migraine is the condition, and it's when you have like multiple headaches. And so you don't just have one migraine, you have headaches. And then migraine's the overall condition. Um, but
yeah,
yeah, it's
my
not, intracranial pressure is going to be like a contributing cause. Like, tell you what, women need all the evidence they can get to
yeah. Oh
participate
no.
in um, research studies that contribute to, no, this pain is not just in my head, or
Mhm.
maybe it is just in my head, but now it's measurable.
Yeah.
And
Yes.
if
And
it's
now it's
measurable, we can
yeah.
act on it.
Mhm. Yeah. So my cousin and I, my cousin's a female, but around the same age, we ended up getting migraines probably once every 2 weeks, something like that. But
Oh, man.
the aura, the
Oh,
nausea
yeah.
that turns into more than nausea, the
Mm-hmm.
completely debilitated for like 24 to 48 hours. It was miserable. And so I cannot even picture having that every other day.
right?
And yeah, to your point, just being able to put something on to say, is it or is it not? I mean, there's a recent kind of Nature review of people that have actually then been diagnosed with uh, elevated brain pressure that looks like chronic migraine. They call it
Mm-hmm.
idiopathic intracranial hypertension once you're officially diagnosed, which the only
Mm-hmm.
way to do that is to get a lumbar puncture today.
Yeah.
But those patients end up having problems with fertility, right? They are
Mm-hmm.
predisposed then to preeclampsia and gestational diabetes. It's not just a headache at that point. It is all these ramifications of not treating that and the long-term consequences of it. So if we can just be a source of fixing that, I think we've got a long way to helping a population in need.
Yeah. I think there's a lot of potential here for um, increasing the conversation around um, all these different symptoms, right? And even looking into maybe more symptoms of long COVID, because, so many people talk about the brain fog they have afterwards. They feel fatigued and lethargic. They get dizziness. They feel confused. They may have bouts of nausea and vomiting and vision changes, which those are highly concerning.
Yes,
But
yes.
to be having those so regularly or almost constantly after having a bout of COVID that feels like it never really left, um, having additional diagnostic tools to work with to identify some of the problem areas can be really helpful to know how to treat it and not just slap a band-aid of pain medication on it, but actually hopefully getting to more of the causes. Because if you're not even able to measure the effects, being high intracranial pressure,
Yes.
then how are you supposed to find a cause,
Yeah.
right?
No, absolutely. And viruses are such a nasty thing. I mean, you could have any, like, meningitis doesn't necessarily start by, swelling the brain and things like that. And so when they're doing kind of follow-up studies with COVID and especially long COVID, and they're seeing hallmarks of elevated brain pressure in scans,
Mm-hmm.
yeah, maybe we wouldn't have used it the first few months and said, whoa, let's stop with the ventilators and go straight to the brain. But with specific patients and specific presentations, there could have been a situation where, yeah, we could have maybe prevented the long COVID, um, you know, by reducing pressure at the same time. And so by just having the tool available to do that and just, investigation, I'm sure there was somebody wondering about that, some doctor wondering about that. If they just had the tool to look,
Mm-hmm.
it would have gone a long way to trying to understand this in a much faster fashion and potentially getting the treatments that much quicker. So,
Exactly. So I'm really thankful you've been able to do some research already comparing it to our current ICP monitoring tools
yep.
to
Yes.
actually compare these apples to apples, as
Yeah.
it were,
Yeah.
because we need to know if it's reliable. So I think I need to ask you a $1 billion question, Ryan. Are you ready for this?
Um, I'm ready. Hit me.
Okay. So if you were given a grant for $1 billion, how would you like to see it used to meet the needs that you see and have the most sustainable impact?
The $1 billion question. I mean, it's a great question.
And I know you like to apply for grants, so
Yeah,
you should be
yes.
able to fill out a
Yeah.
form on
Well,
this.
I
So.
don't, nobody's even let me put my co-founder won't even let me put a B on there. So I would try.
Okay.
I would try. Let's see.
You try.
But
The
yeah,
worst they can say is no, right?
right. Yes, absolutely.
Yeah.
But so we've talked a lot about kind of the unknown in the space. I think intuitively, neurologists, neurosurgeons, even kind of lay people thinking about, concussions and things like that. Logically, the pressure on our brain is important, and we know that it goes out of sorts in a lot of different ways. And a lot of that research comes from the pillars in our community, right? The Mass Generals, the Cedar Sinai's, the Mayo Clinics, right? It's the Cleveland Clinics, um, which it should. I mean,
Mhm.
they have wonderful resources. However, looking kind of just across and where these people present and where they go and don't go to hospitals that are susceptible to some of these conditions, whether it's traumatic brain injury, stroke, all the way down to those chronic conditions. It'd be so interesting to me to use that money to just essentially blanket deliver our readers to all sorts of hospitals across the US, but also in other parts of the world where, we treat traumatic brain injury, fairly well, and we still have a lot of problems. There are places in the world where they have almost no ability to do those invasive procedures. Just trying to understand how it impacts us, why it impacts us, so that we can make a concerted effort to change that, right, from the treatment perspective. I think it'd be a wonderful use of funds just to be able to put them everywhere so that we can collectively just take a step back and say, hey, what's happening here? How essentially have the blood pressure cuff everywhere that it is today, have a brain pressure cuff at the same time. So I think that would be a wonderful use of funds. And I think the outcomes of that would have quite a lasting impact on the community at large. So,
yeah. And when you talk about impact, let's revisit something for a minute. Stroke nurse here. Stroke is the number one leading cause of disability in the world. But you know what's coming up on that? Headache. Headache is a leading cause of disability as well. Maybe not forever, but people taking FMLA and missing work days and it affecting their whole family. Like if we look at like adjusted quality of life days, like that's a lot of the population. Like 800,000 people a year have a stroke in the US alone. And I don't have the numbers for migraine off the top of my head, but everybody knows someone who experiences a lot of headaches. So there's a lot of potential here, and I am really excited about finding out more through safe research.
As am I. Yeah. Headache is the number 4 complaint in the emergency department still. Yeah. It's incredible.
And it has a great effect on their mental health. That's one thing I meant to say earlier, Ryan. Sorry. In case you needed more talking points, I'll just feed them to you, right?
Yeah.
But I mean, so many people who suffer from chronic pain are struggling with depression because they can't imagine life without that pain. They don't have hope that they will be pain-free. And so they may have some suicidal ideation. And so if we want to address a lot of these mental health issues, then addressing the physical causes of their pain has to be part of it.
Oh, yeah. Hope is a powerful medication. And without it, it's really hard to recover. I think that there's been studies in that in idiopathic intracranial hypertension, so those chronic migraine patients, they have higher substance abuse problems. They have faster neurodegeneration. They have horrible quality of life. They have, for women specifically, have 6 times the suicide rate. I mean, just looking at that very specific population, experiencing those very specific pains without hope, it certainly leads to some devastating things beyond what we think of as traditional health-related quality of life. It's devastating for them and their families. So if we can be a small part of that correction, which I think will be a very large part of that correction, but if we can be a very small part, I think we'll have done a wonderful job.
Well, I am definitely team let's fix this. So thank you so much, Ryan, for sharing your billion-dollar vision and putting some of this into context. And if people would like to learn more about CranioSense and the work you're doing, where can they find you?
We're at www.craniosense.com. You can also email me, there's no secret here, R. Myers, MYERS, at craniosense.com. I'd be happy to talk to anybody. We get everybody from doctors to patients, to concerned mothers and concerned daughters. So reach out. We're a community. Yeah.
Well, that's a big open call there, so I hope you don't regret that. But I'll put it in the show notes.
No, that is our mission. No regrets. Nope.
Excellent. Awesome. Well, thank you, Ryan. And if you've enjoyed this episode of the Nurse Rosa's Insights podcast, be sure you subscribe on whatever platform you are listening, or if you're watching on YouTube. Either way, please rate this podcast and leave a comment. Let me know if you learned something, or if you know someone else who has a $1 billion idea that can address some of the world's health needs, then send them my way and we'll shine a light on their ideas. And I'll see you in the next episode.